Oh, indeed, we have begun. So basically, I made a big deal about all of this. Now, I mean, just to review the anatomy and look at the nephron, and really, these are the first part. This is when we talk about glomerular filtration as a significant part of kidney function. And again, the filtrate is everything effectively but proteins and the formed elements in the blood. So all this is a unique kind of tuft of capillaries that are fenestrated. And we went over in anatomy, but what it means is they have these tiny little holes. Fenestration is basically a window. They're very, very porous, and you can adjust the size of the clefts so flow can be regulated physiologically. And really, the sort of the secret to the kidney is it kind of does it itself. By and large, we don't have to worry about that. And again, part of my spiel about this, so to speak, is we often don't. And that can be problematic. And so we don't, and that's these foot processes, that's really what controls the podocytes. And they play with those filtration slits. That's how they're regulated. We don't have to look necessarily through all these slides. They're not going to ask you to do that. But to understand what really makes this is from the glomerulus, everything is effectively, all of the filtrate is captured in a unique system. And really, it's the start of this series of funnels, and it's called Bowman's capsule. Okay, some of you will call it the glomerular capsule, but if you see the term on the test, Bowman's capsule, that's what they're referring to. And it's an enclosure that exerts a certain amount of pressure, a certain amount of tug that assists the process of allowing the fluid basically, and it sort of spritzes out. I mean, you have this little knob, and this is a high pressure filter, and basically what happened, all of this filtrate is spritzing out with all the things, myriad of things that are dissolved in it, and they're captured by this capsule, and effectively, just like a giant funnel, it all leads into stem, is the start of this series of very important tubular systems that immediately start reclaiming material and secreting material. So you're going to see there's a combination of tubular reabsorption, which mostly occurs in the proximal convoluted tubule, and tubular secretion, which for the most part, even though proximal convoluted tubule has a lot to do with secretion as well, pretty much when it's almost only secretion, we get to the distal convoluted tubule with some selective amounts of reabsorption occurring, as you will see, depending on mostly on fluid and sodium at that point in time. And in between them, you have the nephron loop, and as you will see in the glomeruli that are in the cortex, not a big deal, that nephron loop. Really, it's most of the activity is about the reabsorption and secretion process is about the distal and proximal convoluted tubules, but these long loops of Henle in what they call the juxtaglomerular, meaning next to the juxtamedullary nephrons that are right next to it, that are right next to the medullary portion by those pyramids, they're the big player in concentrating urine. So what we're effectively describing is the nephron, truly the structural and functional unit of the kidney. And so we'll take a look. So the proximal convoluted tubule, a lot of microvilli, that surface area, a lot of mitochondria, they're busy. 2/3 of all the absorption and reabsorption and secretion occurs there, on the cortex. And so, and that's where cellular, even the images they produce here, give you an idea. The more of these they have, the more it's about surface area, the more of these they have, there's a lot of it. Mitochondria mean active transport. There's a lot of active transport. So like I said, a quarter of your blood supply at rest is going to the kidneys. Why? They need that oxygen. They need that circulation in order to function. The nephron loop has a thin descending limb that you might remember is permeable to water, and a thick ascending limb that moves solutes around, but basically no water. And we get into that, and I'm sure we're going to get into that Friday. That's that countercurrent multiplier system. That's kind of a long discussion to have, and it may even take over until Monday. So you may really be stuck with me. I'd be upset. I always wonder why my wife keeps her or earbuds in place when I'm talking. What does that tell you? And so the distal convoluted tubule, as you can see, much less processing that goes on, much less in the way of mitochondria. And the schematics tell a story here. And this is what it looks like. If you down the road, if you're have a histology course where you're studying tissue samples, this is a slam dunk. This is the capsule is what surrounds it. This is the space. This is a typical. I mean, there's nothing in the world that looks like that. And these are tubules because they generally have a lining of simple cuboidal. These are all simple squamous, and I mean, it is just a slam dunk for kidney. Can't beat it. And I mean, you can look at these, and I'm not really care about the different cells that are there. In that sense, I don't think that's major anatomically. So, and what happens is eventually the distal convoluted tubules, multiple of them enter in these collecting ducts, and the collecting ducts, as you will see, parallel these long loops of end length, and that gives them that medulla, that classic striped appearance. Okay, and effectively, they all come together and trip out urine, and the urine doesn't get processing. So they talk about these different cells. That's fine. I don't think it's a major player for us. This is, you might recall me telling you in anatomy, these are spread apart so you can visualize it. The structures, as you might have guessed from that micrograph, very, very close together. The tubes are next to each other, and you'll see that when we talk about the juxtaglomerular apparatus. It's really just key to understanding how it interplays with pressures. So, noteworthy things. The afferent arteriole is always going to be wider than the efferent arteriole. We typically control flow by either opening or closing that afferent arteriole. That's the auto controls, the self-control that the kidney has. Here's the Bowman's capsule. Here's this. And then, so this is like, let's say this would be a nephron loop. This would be probably a short one. And you can see multiple entry points. Here's the distal convoluted tubule. And that's about all you really need to see with that. So about 85% of the nephrons, their job is to deal with all the solutes, all the stuff that's dissolved, whether it's glucose, whether it's other chemicals, whether it's amino acids, whatever it's reabsorbing or secreting. Variety of charged particles, 85% of them, and they're almost all in the cortex, hence the name cortical nephrons. The juxtamedullary just means next to, those are those long nephron loops. And that's what we'll deal with when we start talking about the countercurrent system. See, I would be confident that when we do the next one of our tests here, that there'll probably be a question about using that countercurrent system, because I think you really need to know it. So here's what they look like. These are called the vasa recta. That's the capillary bed. And vasa recta means straight vessels. And this idea of the hairpin terms, that's going to be the anatomical basis of this countercurrent system. So all I want to talk about for now. And these are called peri for around, tubular, because it's around the proximal, and distal convoluted tubules. So you can see the loop is relatively short. And notice the proximity, how close they are together. That other illustration was more to just show you, to identify them, as opposed to this, which gives you a better idea of the relationship and the proximity of the tubules to the glomeruli, etc. And so why we see that coloration, again, this is where the energy is. We're utilizing the active transport in the proximal and distal convoluted tubules, why the blood is changing now from arterial to venous. And here, it's very much part of that countercurrent system, okay, where water moves freely, but in order to continually balance it out, we have to actively transport solutes, as you will learn in the thick portion, the thick, long upper limb of that long loop of Henle. So basically that's it, okay? Juxtamedullary, vasa recta, peritubular capillaries, glomeruli, afferent and efferent arteriole that are there. And then the afferent arterioles, they're large in diameter. They are designed to resist that high pressure, but as you will see, the high pressure is imperative for them to accept this remarkable amount of pressure and volume that's coming in. They've got to be able to accommodate that in order for the filtration to work. That you're going to see the pressure in a second. And then the peritubular capillaries in vasorecta are different. Okay, they're low pressure. By this time, the pressure has been sort of absorbed and utilized as a way to generate the filtrate. Okay, and these happen to arise from the efferent, just like the vasorecta. Here, these are thin-walled, and by definition, that again would be a low-pressure type of situation that's there, and we'll talk about how they concentrate. And it's what they look like. So what you can see, afferent or incoming, and then efferent or outgoing, and you can see here's going into this particular glomerulus, just what they look like, and then efferent, outgoing, and because we can adjust that diameter, the efferent arteriole to a much lesser extent. If you wanted to paint with a broad brush, the more flow of blood into those glomeruli, the more filtrate that will be generated. The more filtrate, the more urine. So when we need to get rid of fluid to sort of adjust and lower and sort of maintain our blood pressure. Look, you take somebody's blood pressure, it's like anything else, it's a snapshot. So if your blood pressure is slightly up for whatever reason, you drank a lot of fluids, you had a lot of salt, pick a reason. You're stressed out, you had to deal with me for a class. What'll happen is that will generate an increased amount of flow here. So what will happen is this door will open, so there's more flow here. This will even narrow a little bit. It'll prolong the fluid in the glomerulus, generate more filtrate, means more urine. It means you're going to excrete more. So that's an auto control. You have basically, it's all about fluid balance. So the more fluid we filter, 99, which the 1% of it is going to become urine under normal circumstances, and that will readjust it as needed. By the same token, if you're outside, if you're working out, if you're running around doing a lot of stuff, you reduce the flow. That fight or flight comes into, even to a limited extent, there's less flow to the glomeruli, so you don't have to. You're effectively, you're redirecting the fluid, you're redirecting blood flow to where you need it, and just keeping minimum blood flow. So maybe it's after the workout, maybe it's as you get back to your room or as you get back home, and as you rehydrate, all of a sudden you go, oh, I gotta go. It's different. And I have that effect. I have a urogenic effect because students are always walking out. I'm the guy who's 74, or going to be. I should be the one running to the bathroom. I was the one who had prostate surgery. Makes sense. I have that effect on students. Just watch. You see my A&P class. It's like, that's probably the P in A&P. That was clever. Hey, so every so often I strike gold. My wife will say, that was actually funny for a change. I keep telling her you'll want to meet her. I know. Here's what she would do. You never told me all those girls were so cute. It's exactly what she would do. It's okay. Every so often, our best buddy, his wife, tragic after a 10-year battle with breast cancer. They were married for like 50 years. And we're kind of like an extended family. And for whatever reason, he every so often, somebody we know will be playing at one of these bars, and my wife will go along. And she's surrounded by. She goes, and they always say, doesn't your husband mind? I go, no. He's surrounded by 20, 21-year-old girls all day long. If you don't have confidence in your significant other, it's not stuff you're supposed to worry about in a successful relationship. So this is the big way that this auto control system works. And this is a revisiting that we did in endocrine, the renin, angiotensin, aldosterone mechanism. We see it again and again. We see it in blood pressure. We see it in endocrine. So it's the which means next to, glomerular complex. So typically we see it in the ascending limb of the nephron loop, just when it's getting ready to basically enter into that distal convoluted tubule. Mostly in the afferent, but occasionally even in the efferent arteriole. So we'll have little ways that can be adjusted, and it regulates the amount of filtrate and therefore blood pressure. This is the auto regulation. So what you'll see in the ascending limb is called the macula densa. Unlike the macula lutea, don't get confused with that structure that's in the eye. These are chemical receptors that sense salt content. And that's one of the ways. Remember, what will elevate blood pressure if we have salt and we pour water to it? Okay, so it deals a lot when we see abnormalities in salt concentration. Okay, we've either pulled in too much water or we don't have enough water. So additionally, those are chemical sensors. They are intertwined with these granular cells that are in the arteriole or in the smooth muscle of the arteriole. They are mechanical receptors. They're able to sense blood pressure changes, okay, in that afferent. And again, that's usually the more sensitive of these. And they also contain secretory granules of renin. That's the chemical. So in between the two, between the arteriole and between those tubular cells, there are gap junctions, and this is how the signals pass between them. So mesangial cells, I think of messenger. Angio means blood pressure, but I remember the name because I think of messenger. And it's a really good illustration. Here you can see those extraglomerular mesangial cells. So we may typically, the smooth muscle apparatus is on the afferent, but you can have some on the efferent arteriole. They're in close proximity. Here you have the macula densa, okay? So these are the chemical receptors. These are the pressure receptors, and the granular cells will produce this renin. And depending on the need, they will either open or close it. So remember that mechanism. You're going to see it again and again. And renin, angiotensin, aldosterone mechanism. It's so terribly important, and we don't really have to, and you and I don't have to give it a second thought per se, okay? Because it works. So again, 180 liters of fluid, more or less. So I mean, you can do the math any way you want to do it. Think of how many liters of fluid are being produced. Your kidneys are really busy. So I mean, that if you assume 6 liters, that's 30 times a day. It's basically generating the equivalent of what your blood circulation would be. And we have only 1.5 liters of urine. So they're filtering through the entire plasma 60 times a day, 2.5 times an hour under normal circumstances. A quarter roughly of the oxygen when you're at rest. Okay, and the filtrate is just plasma minus the proteins and by definition, you remember, because we did the blood unit, remember that supernatant liquid is the plasma. What do you have underneath it? White cells, platelets, and red cells. So plasma minus any of the proteins are in there because the formed elements are too big to get through those fenestrations and other little clefts. And so it's 1% and waste products and unneeded substance. And so, and there's variations depending on, so we know, as you will see when we look at urine, what the normals are that are there. There are things that are not supposed to be in there. We're not supposed to see blood, which you might see from this because look, there's no blood cells should be in there. There's no proteins that should be in there. We should have a normal amount of acidity. We shouldn't see things called casts. You should see things called crystals. Interestingly enough, there's an immense amount of information you can get from a complete blood count and a urinalysis. Those two tests alone, very inexpensive. And a urinalysis, which by definition is non-invasive, clinically, so easy. I mean, you can dipstick and microscope it, and a whole lot of information. and of something that you didn't have to basically stick a needle into somebody to figure out. So these are the big processes: filtration, reabsorption, secretion. So the filtration, cell and protein free; reabsorption, 99%; secretion, move substances from filtrate to the renal tubules and the collecting ducts. And they just go through this. And I don't get a lot out of those. It is passive. And this is the idea of basically what filtration is. It's not a whole lot different. I mean, when we think of filtration with a typical drip coffee pot, the pressure comes from gravity. I mean, it's up there. And somehow the water, heated or not, works its way through. So in this case, it's a porous membrane. It allows water and solutes smaller than plasma proteins. Cells don't make it. The fenestrations are there. And they'll go through all this. It's a very accurate illustration when you see the actual micrograph. All those little slits and these little foot appendages they call podocytes. Cells that have little feet. Podo is for feet. Okay. Voila, you get, and it will open them up. And then additionally, they have the fenestrations as well as these clefts. So that more of the wider these are open, the more stuff's going to come out. Actual micrograph. Pretty neat. And this just shows you how it's going through the slit. So as you can see, some large ones might be engulfed, okay, and get stuck in those membranes conceivably, but most of the molecules smaller than 3 nanometers, whatever that is. Water, sugar, amino acids, and remember, job one, nitrogenous waste. I used to joke about it. The kidney is like the Sopranos. You know, and used to go, what? I mean, you always say it's waste management consulting, basically. That's the kidneys. We're a nitrogenous waste removal. No Sopranos fans, huh? Make the case, Game of Thrones. You want to throw in Succession recently, and Sopranos were the best shows ever on HBO. Could have made HBO into that continuing ensemble dramas. Just saying. So, plasma proteins remain in the blood for colloid osmotic pressure. Here's the numbers. Okay, blood pressure. By the time it gets to the glomeruli, it's still high. These may not seem high to you considering it left the aorta at 120 under normal circumstances, but 55 is pretty high when you start to have all that branching off. You see this, look at the size in the diagrams between the aorta and something that, would be a quarter of the size of a pinky in diameter. And so imagine how that is. And typically when it gets to a capillary bed, this is more than double. So the efferent arteriole has a lot of resistance and a diameter smaller than the afferent arteriole. So that efferent arteriole, by its smaller diameter, inherently keeps fluids in there longer. They just take longer to get through. That's a mechanical thing. So the hydrostat, now what keeps it in, there's pressure in that space, and there's colloid osmotic pressure. Remember, the proteins are still in there. So if you have 55 forcing it out and 45 holding it back in, the net force is 10 milligrams. That's why when you have a drop in blood pressure significantly, when someone's diastolic gets like under 80, they're going into shock. And the kidneys have one response to damage, to infection, to lack of pressure. They shut down. That's all they do. Kidneys shut down quickly. Mine shut down, I was telling you, because of that salmonella infection. Effectively, I was in shock secondarily to a bacterial toxin. So it was almost a form of what we would call endotoxic shock. I was there. And I told you how life-threatening it was. Oh, I never want to be that sick again. So that's the net, and we call that the factor. And what you're going to learn about is the way we measure this called GFR, glomerular filtration rate. That's really important. That's the only number we need really to assess how efficiently kidneys work. We get it. We can estimate it from lab tests, but the reality is there are better ways to know it most accurately. Let me just show you illustratively what this means. So the volume of the filtrate formed per minute by both kidneys around 125 millimeters per minute. So it's related to that filtration pressure, surface area, and how many viable glomeruli. Then now we start getting into kidney damage, how permeable they are, much more permeable than other capillaries. Assume you haven't had something in them that has caused them to be damaged. And there are things that damage them. Diabetes damages them. Certain toxins damage them. So retrospectively, for people like me, you think more about as you get older. You think about, I mean, it's this whole idea, and I've been telling it to a lot of the clients, this whole idea of young people, other than having special circumstances, are generally not in touch with their own mortality. You don't think it could happen to you. You don't think something terrible is going to happen. I don't blame you. Most of us don't until something happens. And it's preachy, but it's better, I don't care what you do. I mean, I can't even tell you how many illicit drugs we used. We were in that, it was that Woodstock. I told you, it was the summer before I started in college. Imagine the stuff, I was going to say shit, that we did. I mean, hallucinogenics, people were doing cocaine, they didn't even know what it was. Oh my God. I mean, amphetamines were easy to acquire. I mean, honestly, if there was this, I remember my second year in I stayed in a dorm for the first, I transferred, it was a good thing. Second year, this guy, he's one of those guys who had like the refrigerator and the microwave before it was fashionable. And so he had a cottage industry of selling snacks. And he goes, there's a big sign, this. He said, if I'm not here, the door's open. Greenies, which were a form of amphetamine or speed, so you could stay awake and study all night, are $1 a piece. They're in my top drawer. Just leave the money. I mean, that's how open it was. It was hysterical. It was wild. If you, they hadn't looked at a book for a month. They have a big exam. Well, I'll just pull an all-nighter, which I didn't do. I used it more recreationally. It was great to play cards with. You never forgot a card. And I generally don't forget cards. Gin Rummy, I remember all the cards that are played. Bridge, I was a competitive duplicate bridge player. You gotta remember every card. Not anymore, I don't try. The guy I graduated with, very smart. We were like, three of us were really the smartest guys. We were equal. It was the early days of Atlantic City, and he would card count. He was really good. I mean, he started one of these. At that time, you could find it at $2 and $5 tables, and I mean, and when the cards are favorable, you start to bet it up. I mean, he's counting every single, because he only used 4 decks. Moving on. So the GFR is extraordinarily important. Okay, and it's homeostatic. These are intrinsic controls. It's auto-regulated. So the glomerular filtration rate is all about these things. And so the whole idea of any controls on it are to maintain your blood pressure. So we have nervous and endocrine controls that work outside of the kidney, but by and large, the kidney auto-regulates itself. Remember that number I talked about, that mean arterial pressure. As long as it's within that range, you don't have to worry about it, other than extraordinary circumstances. Here it is. autoregulation ceases out of that range. And they talk about these different mechanisms that are there. Myogenic means how much it's stretching, the smooth muscle. Tubulo-glomerular feedback is different, more chemically oriented, osmotically oriented, So smooth muscle, we know it contracts, blah, 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 blah. But this is the myogenic method is basically if your blood pressure goes up, the muscles stretch, okay, and what will happen is because of that, the afferent arterioles, which are strong, will constrict so you don't damage the glomeruli. The big problem is the capillary bed is the one that's subject to pressure changes. It can tear. Persistent high blood pressure eventually will damage that. Then they're going to effectively become limited in their capability and long term. That's one of the big problems. One of the big problems with people with high blood pressure, what they call the silent killer. And effectively, a lot of times we don't know what happens, but down the road, now the kidneys begin to be progressively damaged. And again, this is one of those things when people don't know they have a high blood pressure. A lot of times they find out when they've had a stroke. When they go to the doctor for an insurance physical, and all of a sudden they're getting terrible headaches, and they're like, "Oh my God!" And they start looking at the kidneys, and they always see tangible damage, and it's not going to make itself better. It's not like a magical repair mechanism. You're going to now have X percentage of your kidney function limited. So that's a protective mechanism. Decreased blood pressure, the opposite that are there. And again, effectively, you're maintaining it, yet maintaining the overall health. And so these are flow dependent at the macula densa. That's the soil concentration, et cetera, et cetera. You can read through that. So outside of that, so assuming those controls were outside of the range or there's something extraordinary happening. So they regulate glomerular filtration over and above it. Sympathetic nervous system. The kidneys have no parasympathetic because it's all blood vessels. There's no parasympathetic. The parasympathetic won't slow it down, okay, or speed it up. The sympathetic nervous system, that's fight or flight, is going to restrict blood flow and lessen or close down other than the minimum needed to maintain viability. So under normal conditions, the blood vessels are fine, autoregulation prevails. Abnormally, low extracellular, for whatever reason, you're losing fluid or leaking fluid, and then the norepinephrine released by the sympathetics, and epinephrine through the adrenal medulla, vasoconstriction, constricting the afferent arterioles, blood volume and pressure increases. We're not going to even allow. So that's what happens. You see that in fight or flight, but you see that as a protective minimum where somebody starts to bleed if they've been in an accident. Those are inherent mechanisms to try to maintain the blood pressure until either it can repair itself or they can get assistance in the medical sense. I'm sure I said it to you before, and I'll keep saying it to you. Almost anybody who's interested in medicine at least rotates through emergency. You quickly learn what's the thing, what things are the most dangerous, what can kill that patient, and identify that. Well, they have a little surface cut from something that's going to need a few stitches. Just put some pressure on it, put a pressure bandage on it. Figure out what the heck's going on. You don't have to make it pretty and things like that. You got to figure out what, if they are potentially critical or potential loss of life, address that first. We say, figure out what kills them, what can kill them first. That's sort of the batting order of how you treat them. That's sort of internal triage, if you will, which increases blood pressure, constrict the arterioles, etc. The renin, angiotensin, aldosterone mechanism. This is the big player. So there are different pathways. Those granules can be directly stimulated by the sympathetic nervous system, the cause that system to become active. The salt concentration is low. I mean, it's almost like if you think salt concentration is low, there's an overabundance of fluid potentially. Okay. So, and reduce stretch on the granular cells. And you can look at all of these things. I'm not going to take the time to read through it. So the renal cells also have local agents, adenosine, prostaglandins, etc. Okay. And even some cells make the activated angiotensin that reinforces it. Think of what adenosine is. Adenosine receptors, when we are drinking caffeinated beverage, like this, the remnants of my morning coffee, you're blocking adenosine. And so adenosine tends to lower renal activity. Okay. It's more designed with rest and being inactive and or sleeping. When you block them, if you drink a bunch of coffee in the morning, and not only are you putting in fluid, but you're basically a stimulant, and you're going to end up having to run to the bathroom. That's the way it works. That's probably why the students are running out of my class, even though none of them have touched a cup of coffee. Oh, I had too much coffee this morning. You never drink coffee. Okay, and what happens? Abnormally low, 50 milliliters a day. Okay, so that's bad, and that means you're either not getting enough, renal failure, and it result from a variety of situations. Again, transfusion reactions, injuries, infections, inflammatory changes that are there, etc. I wanted to show you that renin-angiotensin mechanism. If they don't directly show it to you here, back to the top. Just to make sure you're familiar with it. Again, so again, when the blood pressure is low, renin is nothing more than an enzyme. It's going to basically take the precursor, angiotensinogen, and catalyze it to make angiotensin. There's two steps when you look at the pathway that will activate this angio 1. I forget what the enzyme is, but the big player is here. Angiotensin 2. And so this is angiotensin converting enzyme. We use the acronym ACE. So I hate acronyms. That one can be used in more than one way. And that makes angiotensin 2. That's the active one. And angiotensin 2 is a big player. Okay. Angiotensin in general, it has like 4 different ways when we start looking at this, when it's active. So number one is the name gives it away. Angio means blood vessel, tensin, so it immediately squeezes your arteries. That's going to elevate your blood pressure. So it's going to constrict arterioles. You're going to take in more fluid, it makes you thirsty. It's going to increase the production of antidiuretic hormone. That's going to go up. That's going to go up. That's going to go up. They all raise your blood pressure. And most importantly of all, angiotensin is going to stimulate aldosterone release. So with aldosterone increasing, again, you know what that means. So it's going to insert little channels that we're going to get to in the kidney to retain sodium. And because of that, obviously, how many times you want to say Steins? Mary had a little lamb. Water is sure to follow. I love that. I love that. Mary, lamb. What did one shepherd say to the other shepherd? Let's get the flock out of here. Yeah, I shared that one with you. What? That's not my invention. All right, moving on. So the other steps, resorption can go either through the cell or next to the cell, doesn't matter. Okay, it can be active or passive, doesn't matter. The active of it, and because of the amount of ATP, you can see all those mitochondria. There's a tremendous amount of resorption, and a lot of it is active. For instance, we use sodium so much. Sodium will be pulled back, and at the same time, it will co-transport glucose. Okay, so we see not only primary active transport But in this case, you have the secondary active transport that goes along, which is very useful. And you have different routes that are there. So transcellular, it just basically the cell is more or less a conduit. Paracellular, between it, depending on tight junctions, but there's leaky areas, water, calcium, magnesium, potassium, some sodium. In the proximal convoluted tubule move by this way. So those are tiny, comparatively speaking, ions and water are very, very tiny particles, comparatively speaking. That are there. They're just showing it to you, the different things. You can follow those easily. Sodium transport is the most abundant cation in the filtrate. Okay, so again, across the basolateral membrane, primary sodium potassium ATPase pump the sodium into the interstitial space. The sodium is then swept by bulk flow into the peritubular capillaries. So basically, that's the act of transport. And like I said, that's the primary. Anything that comes with it or goes against it, so we'll either have co-transport or symport, that they will sometimes call it, or antiport, anti-transport. So secondary co-transport by a facilitated diffusion plays a role, and so potassium leaks out of the cell, leaving a net negative charge, which also acts to pull sodium inward. And you get that consistent idea of sodium and potassium typically going in opposite directions. It's useful. So, when we think of all the stuff, like I said, I'm trying to share with you the limited amount that I know about it, because I can recall, even when here I am as a medical student, watching one of the interns who had just graduated, all this stuff on the board, because his attending at the vet's hospital was a nephrologist. And it's like, I'm looking at stuff, and he's writing it. In the old days, we didn't even have whiteboards as well. And you come in there, he's got this whole thing written. I said, what's up? He said, I'm trying to figure out all of this stuff, because I've got to present it. And it was Dr. Falls, as I recall the name, because he's a nephrologist, and I got to get it. There was a lot of pressure back then. Maybe they're a little more user-friendly today. Doubt it. So get used to it. It's firing line right away. I tell you, they're just firing questions at you constantly. The senior residents, the junior residents, they're just pummeling you with questions. You got to be spot on the whole time. Be prepared. You work all day, go home, read all night, try to get a couple hours of sleep in, and just keep doing it. So sodium reabsorption is the primary way. Secondary, active transport. Okay, and there's a certain amount of that goes on. Electrochemical gradients, not unlike when we talk about electrical chemical gradients, like we learn about the mitochondria. Okay, so glucose, amino acids, things like that. We have passive absorption of water. That's the osmotic gradient. Okay, so these water are in the proximal, and this is part of what I was talking about. Water easily moves in the proximal. It's facultative based on inserting these into collecting ducts. That's what antidiuretic hormone does. It inserts little additional protein passageways, so water will be reabsorbed. That's antidiuretic hormone. Aldosterone inserts other channels in the same area that are designed to pull sodium and water following it. So it's very interesting. So solute concentration increases as water is reabsorbed, and so concentration grades for the solutes. Okay, and then all of these things move differently. So lipid-soluble fat-soluble ions in urea will follow water. Typically, lipid-soluble drugs and environmental pollutants are reabsorbed, even though it's not desirable. There's a lot of problems with getting rid of certain substances that are there. And this is just showing it to you. I think we're just about done. And yeah, I don't want to, I can't give short shifts to transport maximums. So we will start that Friday and